Hi, Adult Health 1. So this is Module 9. This is our last module. You made it. This is on musculoskeletal dysfunction disorders and trauma. It is not crazy. This is not a long PowerPoint. So it should be pretty easy going. Here are our objectives. We're going to start with Chapter 52, Assessment of Musculoskeletal Function. All right, so musculoskeletal assessment. So we're going to start with the past medical history, right? Simply because past medical history can have implications for current injury or disease. For example, a shoulder dislocation in the past may predispose a person for future dislocations, right? So injury that you did a while ago, unfortunately, can rear its ugly head again, right? They also bring up, the book also mentions that like stuff like hormonal disturbances can have implications with calcium balance. And of course, calcium is, our bones store calcium for us, so that would be a big deal. And then also patients with Down syndrome are known to experience accelerated aging, and that has musculoskeletal implications. So there's stuff, you know, related to genetic mutations and stuff that can happen that can end up having problems for the musculoskeletal system, right? We're going to ask questions related to current complaint, you know, swelling, pain, stiffness, any deformity, weakness, instability, loss of function, color or temperature changes, you know, that's important. Altered sensation like numbness or tingling. Let's see, what treatments has the person been using and have they been effective? And then we're going to do a physical exam. We're going to start with general inspection and then move on to something more focused, right? One of the things though, you want to make sure that you test muscle strength just to kind of get a baseline. And of course, you're going to compare that, you know, is it bilateral? You know, what's going on with that? Labs, we're going to look at calcium and vitamin D, and diagnostics, maybe X-ray, CT, or MRI. This is a safety alert, slide 5. If you suspect an acute bone injury, immobilize the extremity, control the bleeding if present, elevate above the level of the heart if possible. We apply cold packs, okay, and refer to emergency medical evaluation. This is another safety alert. This is slide 6. So nursing implications to be aware of for any imaging study. So this is like asking people if they're pregnant before they go for an x-ray. We want to know about allergies because if we use any sort of contrast and they have an iodine or shellfish allergy, we would want to be concerned about that. Making sure that consents are signed. Let's see. You want to make sure that you place an IV large enough for contrast, right? We don't need that IV to blow after we roll them down to CT or whatever. Renal status, especially if we are using contrast dye, because we want to know if those kidneys are going to be able to process out that contrast. We need to know if the patient's taking metformin. Contrast medium can greatly increase the level of metformin in the blood. In addition to the potential of hypoglycemia, increased levels can also increase the patient's chance of developing lactic acidosis. Metformin should be stopped before the procedure and held for 48 hours after the procedure. And then if your person has had contrast, we're going to want to, if they can swallow, you know, PO fluids. If not, we're definitely going to want to make sure that we have an order for fluids just to help prevent kidney injury with that. Chapter 53, multiple, there you go. MS disorders. We're going with MS. Muscular dystrophy. So muscular dystrophy has many different subtypes that affect many different muscle groups, right? Some are age specific in relation to presenting with symptoms. There's variations in severity, and they're caused by different defects in different genes, okay? So muscular dystrophy is kind of an umbrella term, and then there's all these dysfunctions that may fall under that umbrella term. So they are classified as an inherited group of progressive myopathic, meaning muscle disorders that are caused by imperfections in normal muscle function. Primary symptoms are progressive muscle weakening and wasting of skeletal or voluntary muscle groups. Muscular dystrophy can appear at any age from infancy until middle-aged and beyond. The type of MD and its severity are partially determined by age at onset. Some people with MD have rapidly progressive muscle weakness and wasting and can die young, like in their 20s. Others experience mild, slowly progressing symptoms and have a normal lifespan. There's 9 subgroups of MDs. You do not have to memorize all of them. Each of them do have a distinct clinical presentation, but they all have that progressive muscle weakness and typically present with chronic pain, most notably in the lower back and legs. So because of the progressive muscle wasting and weakness, falls are often associated with muscular dystrophy. So that puts the patients at risk for fractures, right? Progressive deterioration of facial muscles is associated with problems with dental hygiene, speech clarity, and articulation. As a result of immobility, there can be GI dysfunction. The most life-threatening result of this progressive deterioration is the cardiopulmonary compromise that occurs as a result of the development of cardiomyopathy. So cardiomyopathy is a form of heart disease that presents with weakened heart muscles and decreased pumping ability. So it results in arrhythmia, shortness of breath, and extreme fatigue. Diagnosis usually begins with a preliminary review of serum muscle enzymes, which is usually an early sign of the disease and requires frequent and close monitoring. The gold standard for diagnosis is a muscle biopsy. Okay, they look for structural changes in the muscle cells. So gold standard for diagnosis is muscle biopsy. If MD is present and changes are visible, the biopsy, let's see, they use the biopsy to try to narrow down what type of MD the person has. Medical management focuses on prevention of the progression of the deterioration, so supportive measures essentially, right? And anything that can slow that progression down. Also, they may need assistance related to decreasing functional capacity, so walkers, wheelchairs. They may need help with transportation. They're going to need help with pain management for sure. So somebody's going to have to help them manage their pharmacological needs, essentially. A lot of times they'll be on steroid therapy. Let's see. So there's a lot of considerations with this. And again, though, it goes back to age of the patient and severity of the MD. This is just a slide that shows main areas of muscle weakness in different subtypes of muscular dystrophy. So you can kind of see, like, this one is whole body. The one down second on the bottom row is whole body, and then the one next to it is just extremities, right? It's totally crazy. So it presents all different ways with people. RN considerations related to muscular dystrophy, common findings, weakness affects proximal before distal limb muscles. They're going to have difficulty running, jumping, walking upstairs, maybe lordosis in the spine, calf enlargement, cardiomyopathy, Cardiomyopathy can lead to cardiovascular disease. There can be respiratory compromise, falls, fractures because of the falls, and depression, right? Because these people, for the most part, are A&O times 4, and you are progressively losing your functional ability, right? So that can be, a lot of psychosocial aspects related to that. So some of the biggest concerns are physical mobility, loss of muscle tone. Maybe they initially are able to walk independently, and then they have to go to a walker and then a chair, that can be hard. There's risk for dysphagia. If it ends up affecting the muscles in the face and neck. Cranial nerve 7 dysfunction, risk for falls associated with decreased muscle tone, which we talked about. Our assessments, obviously vitals. We're going to look at, all the testing we talked about related to respiratory, like forced vital capacity and all of that, which measures how hard you can exhale. They're going to do all those respiratory tests, because we're worried about these muscles not functioning correctly. So they do not want, we don't want anybody maintaining and holding on to too much CO2. So they're going to be following that. Obviously, chest x-rays and x-rays in general, looking for skeletal structure changes. And then labs, we're going to do enzymes, right? CK, LD, ALT, AST, those are our livers. We're going to look for creatinine, serum creatinine compared to a 24-hour urine creatinine, because we want to compare where they both are, because we are looking at muscle breakdown, right? Deterioration. So we need to compare those to each other. They may do an electrocardiogram. Obviously, we talked about pain. So RN actions, meds as ordered, right? And then supportive, whatever support we can offer, comfort measures, etc. This may be range of motion exercises. We're going to want our patient to be on fall precautions. And then we're going to try to work with OT, PT, maybe even speech, to see what we can do to help these guys. So teaching, just reinforcing that exercise and physical activity and OT, all of that would be beneficial. Who is their caregiver? Who is their support system? What education do we need to do with them, right? If this is progressive, there's going to be an increasing dependency on caregivers. So we need to make sure that the caregiver understands that. And maybe if it's like older parents or something like that, maybe we have to help them and talk to them about looking for someplace for their person to live where they're able to have a more functional life and more support, right? Because we don't always have families who have somebody who can be a caregiver, especially when care is 24/7. So you have to have those hard conversations about where the disease is going. Osteoporosis. All right, osteoporosis is a chronic condition that results in deterioration of bone tissue and density, increasing a patient's risk for fractures. Risk factors for osteoporosis are defined as primary and secondary. Primary risk factors are those that are non-modifiable. So age, race, non-modifiable. So age and race, right? And then there are lifestyle choices like sedentary lifestyle, not enough calcium intake, smoking. And then secondary, we have disease processes. So like Cushing's, or use of steroids related to like immune diseases or other disease processes. So, and also, although not totally understood, Down syndrome is also associated with an increased risk of osteoporosis. They think too that this may have to do with the accelerated aging potentially, but they're not really sure. So the pathology related to this, so bone mineral density peaks between age 25 and 30 years. And then just with aging and other associated risk factors, bone remodeling is altered. Um, so important factors to note with aging that occur are a decrease in calcitonin levels. And calcitonin is a hormone that decreases osteoclastic activity. There's a decrease in estrogen levels, which results in the inhibition of bone formation, and an increase in the parathyroid hormone, which increases osteoclastic activity and bone turnover, right? Parathyroid is in charge of our calcium. So if the parathyroid hormones are decreasing, our calcium is not being regulated the way it should. So all of these changes produce a decrease in bone mineral density. So the bones become like more porous, brittle, fragile. And then of course we have an increased risk of fracture, right? Because the bones aren't as strong. So diagnosis, the gold standard assessment for osteoporosis is bone mineral density measurements for females over 65, males over 70, or anybody from like 50 on who have any like high risk considerations. Okay, so they use a DEXA scan. This is a dual energy X-ray absorptiometry. All right, but a DEXA scan. So it gives a precise measurement at clinically relevant skeletal points within the body. And it basically is able to identify areas for fracture risk. Okay, so treatment really is about prevention. Okay, we want people to be on calcium and vitamin D and doing weight-bearing exercises early on. The earlier you start this, the less risk you have of osteoporosis. So we want weight loss, muscle strengthening. Also, anytime you have weight loss and muscle strengthening, you're decreasing your risk for fall, right? And so the better balanced you can stay, all of that, the more you decrease your risk of having a poor outcome related to osteoporosis. Also, excessive alcohol intake, more than 3 drinks a day, smoking can affect osteoporosis. So we need to do education related to that. There are meds, but again, first line prevention is calcium and vitamin D. Okay, that's what we're gonna recommend. And then there are meds that can be taken. I don't know if you've seen the commercials, but there's like shots and stuff that help with all of that. All right, so slide 12 is table 53.3. This is just primary and secondary risk factors for osteoporosis. So primary includes genetics, nutrition, and lifestyle, right? Notice lifestyle are modifiable, right? And then secondary is medications and disease pathology, which, based on the disease pathology, we may not be able to change those meds, right? So those risk factors may not be modifiable in any way, shape, or form. Slide 13 is a safety alert, essential teaching points for patients on alendronate sodium. This is Fosamax, okay? This is one of the meds you're going to see advertised, or at least I have seen it advertised. So you have to administer it with 6 to 8 ounces of water first thing in the morning before any food or beverage. Do not eat or drink anything for at least 30 minutes after taking the med. Stay upright for at least 30 minutes after taking the med to present esophageal irritation, right? So it refluxing on you. Avoid aspirin and NSAIDs when taking this drug to decrease additional GI upset, and consult your physician for alternative analgesics. So RN considerations related to osteoporosis. Common findings are dowager's hump, where our little old ladies are all humped over, right? That's a dowager's hump or kyphosis. We're going to monitor for loss of height, like people, because they literally say like, I'm shrinking, right? And it's because the bones, everything's squishing in on each other, or somebody is hunching over. And you can lose up to 2 to 3 inches. People may have back pain. They may have pain that with activity relieved with rest. They may have restriction of movement. Also fear of falling because they don't feel stable. We want to know about any other fractures that they've had, recently, history, whatever. So assessments, obviously, we're going to look at fall risk. We're going to take into consideration age because that's a really important aspect to this. Pain, nutritional status. What is their activity and exercise like, right? Are they active or are they sedentary? Let's see. We're going to obviously administer meds as ordered. Lots of hormone stuff with this. We're going to educate about weight-bearing exercises. If we're not quite worried about it yet, if our person is still young, calcium and vitamin D. And our person may need home health to come in. Maybe they need a home safety assessment, right? Maybe we're worried about them falling because they do have kyphosis, and they do seem wobbly, right? So when it comes to taking medications and patient education, there's a lot of instructions related to these, like you have to take it on an empty stomach, the whole thing about sitting up afterwards, right? We're going to talk to them about weight reduction if applicable. So, some things to consider there. This is Paget's disease. So this is the second most common bone disease with approximately 1 to 2% of white adult male population older than 55 being most affected. Genetics have been linked to like 15 to 40% of known cases of Paget's. I'm going to be honest with you, I'd never even heard, I've heard of Paget's, but I've never had a patient with Paget's. It's never come up, but so this is a little bit of an FYI. Let's see here. Sorry, I went ahead of myself as I'm talking. So this is also referred to as osteitis deformans. So it's a bone metabolism disorder associated with accelerated bone remodeling, resulting in bone that is structurally abnormal. The skeletal areas most commonly affected are the skull, femur, tibia, pelvic bones, vertebral column. So imagine how this would affect mobility, right? And then if it's facial, psychosocial, right? If your face is deformed like that, definitely psychosocial. Because of the insidious nature of the disease, a confirmed diagnosis is not known until a fracture develops or occurs. And it is initially asymptomatic. 80% of all PDB patients are asymptomatic. As it progresses, clinical manifestations vary according to the severity, extent, and site of bony involvement. Two main clinical characteristics are pain and deformity in the affected bony site. Additionally, fractures, tumors, neurological disease, and cardiac disease from related dysfunction with calcium and phosphate imbalance can also occur. So finally, our phosphate actually matters, right? Meds, no effective treatment for Paget's, okay? Meds are just focused on pain management, functional outcomes, analgesics, right? They may use opioids because you can get severe pain with this. Let's see. They may use calcitonin. Doesn't necessarily show that it's particularly effective though. So our assessments are going to be about pain, weight reduction. We're going to be looking at our calcium levels, fall risk, gait disturbances. We're going to administer meds as ordered, obviously, always. We may use thermal therapy, right, hot and or cold, to help with increased flexibility and reduced pain. Normally cold helps with pain in like the joints and whatnot, because it helps with the inflammation. And then our heat would help increase functionality and flexibility because it brings more blood to the table, right? Also, we're going to want to talk about, staying active, exercise programs. They may need like orthotic shoes or braces, stuff like that. Um, they may need home health. They are going to probably need support at home. So we would have to talk to a caregiver about what they are able to do or not do. We also want to encourage vitamin D and calcium, just as, do what we can, right? All right, osteomyelitis. So this is a bone infection. This can be acute, subacute, or chronic. The biggest thing with osteomyelitis that sets it apart um, from other things is the pain not relieved by rest. All right. So with other bone and muscle dysfunction, like normally if I'm irritating or like being super active and then I rest, that pain decreases. May not be gone entirely, but it'll decrease, right? The thing with osteomyelitis is that pain is not relieved by rest, all right? Because it is related to infection. So infection is not caring if I am resting or not, right? So it can, osteomyelitis can be related to infectious spread from another site within the body, or it can be related to like an open fracture or trauma to the bone. Okay, and that's how the infection got in. So, like I said, you can have acute, which is less than 2 weeks, subacute, 2 weeks to 3 months, or chronic, which is greater than 3 months. Clinical manifestations, pain not relieved by rest. You're also going to have your signs and symptoms of infection, so edema, tenderness, warmth at the site, all of that. Our labs are going to be our infection labs, ESR, CRP, WBCs. Diagnostics, we can use X-ray, MRI, CT. Our treatment is IV antibiotics for up to 6 weeks. Okay, IV antibiotics for up to 6 weeks. Also, if this is related to open trauma and there's a wound, we can have debridements, we can have washes where they go in and wash out the nastiness and try to get the infection to calm down a little bit. And definitely these people are going to need opioids for pain. It can be very, very, very painful. So common findings are a high fever, all right, especially when we have bacteremia. So we are talking like greater than 101 in an adult. In a kid, 101, not that crazy, but in an adult, that's a pretty severe fever. Again, with the pain, warmth at the affected area. They're going to have difficulty moving because we're going to have inflammation. They're going to have difficulty bearing weight on the affected side, poor perfusion. Let's see. We are going to worry about neurovascular complications such as, burning, tingling, neuropathy sort of things, right? Related to potentially inflammation and damage, okay? Assessments, obviously vitals, temperature, all the things related to infection, pain, wound assessment, right? Neurovascular, remember pulses, pallor, pain, paresthesia, which is tingling or paralysis, right? We're looking for signs and symptoms of impaired circulation. That is our biggest concern. Obviously, this would require prompt intervention. Lab tests, WBCs, ESR, CRP, cultures, wound cultures, blood cultures, all the cultures, just to see what's happening, make sure nothing has spread. We are going to administer those IV antibiotics. They are very likely going to be 6 weeks, on a good day, maybe 4 weeks, but usually 6. We don't like to mess around because of multi-drug resistant organisms these days. So you really are, I've only seen 6 weeks related to osteomyelitis. Again, we can use hot and cold. We may use gentle, like range of motion exercises for people. because we want to prevent contractures. So we don't want these guys getting any weaker or more debilitated than they already are. We worry about falls and nutritional support. If they do go home, they're probably going to go home with home health, at least checking in on them. Um, we want a high protein diet, just it helps with healing, right? And then, of course, reporting if any signs or symptoms get worse, let the physician know. All right, scoliosis. So this is not a diagnosis, but a description of the structural alteration that is noted by a curvature of the spine greater than a 10-degree curvature, okay? Normally associated with rotation and compression. So we have neuromuscular, congenital, and idiopathic. Neuromuscular is in patients with neurological musculoskeletal problems like cerebral palsy, myelomeningocele, muscular dystrophy, or leg discrepancy. So like one leg is shorter than the other. Congenital scoliosis is asymmetry in the vertebral column, secondary to a congenital anomaly. And idiopathic scoliosis, we don't even know why, right? Don't know what's up with that. So scoliosis can be a sideways curvature. You can see uneven shoulders, uneven waist. One hip maybe is like higher than the other. We do worry about how this affects breathing and the respiratory system because our lungs are hanging out in there, and as scoliosis worsens, part of the problem is people get really hunched over and you're literally squishing your lungs. You're reducing the area that they have to expand and inflate and deflate and all the things that keep us breathing healthy. So a lot of times you do end up with cardiopulmonary compromise related to this. So tachypnea, tachycardia, shortness of breath, and decreased oxygen saturation. I used to take care of a kid with cerebral palsy, and they didn't expect him to live till age 2, and he actually lived till age 17. But what ended up doing him in was he had severe scoliosis going on, and he ended up with severe pneumonia. And they opted not to do any spinal surgeries on him, because with spinal surgeries afterwards you have to lay flat for like up to a year. Sometimes they put in all this hardware, they straighten everything out, it's very painful. And he had severe cerebral palsy and would not have been able to understand what was going on, never mind lay flat on his belly for months at a time. So he ended up dying from pneumonia related to the scoliosis, right? Because that area is all scrunched over and he couldn't clear all that fluid anymore. So this really can be debilitating for people. So treatment for scoliosis in the adult population, if a curvature is less than 50 degrees, then they use like thermal therapy, physical therapy, OT, exercise, pain management. Pharm is focused on comfort and pain. It can be aspirin all the way up to opioids, depending upon what's going on. Thermal therapy, we're going to use that to reduce pain, promote comfort, assist with spinal flexibility. If I'm using heat, again, that gets all the blood to the table. And when we get increased blood to the table, that helps with circulation, helps with pain, opens everything up. So that's going to increase my flexibility. Also talks about exercise and all of that. Surgical interventions, when that spinal angle is greater than 50 degrees, and they only go to that after conservative treatment has shown to be ineffective. So they use spinal fusion or spinal instrumentation. So the instrumentation, rods, screws, all of that thing. Afterwards, they also have to wear, we always called it a turtle shell, but it's a TCO or TLSO, thoracic lumbar spinal orthotic, or a total contact orthotic. So it's a brace that fits around your core, essentially. Some are wider, like stretch all the way up from like your clavicles, down to past your waist, almost to your pelvis. And there's some that are more around the rib cage area, right? The little kid I used to care for, he had one, and we just called it his turtle shell. And it attaches with Velcro and stuff. But like the biggest thing is like with any brace, you have to worry about irritation in Arizona in the summer, sweating. So you can end up with kind of like a contact dermatitis, eczema situation going on related to skin irritation and skin breakdown. So basically the turtle shell just kind of helps hold everything in place, and it helps with posture, especially when we're talking kids. So it'll help with instability and flexion, in rotation, just doing things wrong because it braces everything, just like any other brace. RN considerations related to scoliosis. So pain, obviously. We're worried about kyphosis. We're worried about asymmetry of the hips. That's going to affect how somebody's walking. And when your hips are off, then your knees start to hurt, your ankles start to hurt. That pain radiates to other areas because you're compensating, right? We, of course, worry about that cardiopulmonary compromise. Related to the curvature of the spine, the degree of the curvature. So these people can have physical immobility. They may have to look at going to a wheelchair potentially. We worry about falls. We worry about fractures. And if your person is alert and oriented, we worry about body image disturbance, right? Psychosocial aspects. So assessments, vitals, pains, safety, actions, meds as ordered. We're going to be wanting to assess orthotic devices, making sure that there's no points of rubbing or pain or irritation, that it fits the way it's supposed to fit. And if you're talking little kids, like you have to have kids like every 6 months go in and have them fitted for their braces because they're growing. Even kids with muscular dystrophy and cerebral palsy, they're growing and changing. So you have to make sure as your child is growing that the braces are being fitted appropriately. And then of course thermal therapy, and that heat therapy is going to help with flexibility. Teaching is going to be related to all of that. All about the braces, all about falls, meds, keeping your person active and exercising. Swimming is a great activity that we're really able to do in Arizona most of the year because it doesn't allow for a lot of pressure to be on the body, but you can get full range of motion in good exercise. So, all right, moving on to joint replacement. Arthroplasty. So total joint replacement, or arthroplasty. There we go. Most commonly associated with the joints of the hip and knee, but actually they can do any joint within the body at this point. So osteoarthritis is the leading clinical indication for a joint replacement. They actually take out the damaged areas of the bone and replace it with a prosthetic. It's really pretty cool. If you've never seen a joint prosthetic, I would Google it. It's just kind of cool that they can do that. You definitely look like a robot. So determining need for joint replacement is based on deformity, tissue destruction, loss of function. It's also based on age, because at this point they can only do a joint replacement twice during your lifetime, because they have to cut away some bone and cut into some bone to secure the joint, the steel replacement. So they can only do a joint replacement twice. So like my brother is 48 and desperately needs his knee done, but they don't want to do it because he's still so young and likely, probably has about, 25, 22 to 30 years left of life. And they don't want to replace it this early because if he has to have it replaced again, then he's SOL, right? So in 20 years would only put them at 65. So it's really interesting how they take all of that into consideration. And just because you have deformity and loss of function, if your age doesn't fit the criteria, then they say no. Um, let's see. So they are going to identify need for a joint replacement through an X-ray. They can do MRI, so you can see a little bit more structural stuff that's going on. They also want to do weight management, activity modification. They're going to try NSAIDs, even joint supplements like glucosamine and chondroitin, all of that conservative management before they get into doing a joint replacement. So complications, most immediate post-op complication, hypotension, bleeding, hypovolemia, if there's excessive blood loss during the surgery. Afterwards, with a wound site, we worry about infection. We always want to make sure that people are using pre and post-op asepsis, washing hands if there's a drain, if somebody goes home with a drain, washing their hands before they empty the drain, washing their hands before they change a bandage, all of that stuff. The biggest, and then the other thing with a joint replacement is those joints can pop out of place. So dislocation or subluxation, or partial dislocation even. So there's a lot of patient education that goes along with a joint replacement, because you can pop that sucker out of joint and then you go back to surgery, which is not fun. Common findings are going to be pain, right? Loss of mobility and joint function, activity intolerance, risk for infection related to the surgical site. So we're going to do all the pre and post surgical stuff. We're going to talk to our person about pain management, ambulating your person early. When you get a joint replacement, like they walk you the same day. You are up and walking, right? Out of bed, doing the things. So they want you using that right away. Obviously, we're going to watch for vitals, temperature, labs. We're going to want to make sure, we're going to look at our H&H just to make sure that we don't need to transfuse, especially if there was a large loss of blood during surgery. We're going to do our neurovascular assessments, right? The pulses below the site of the new joint, right? Pallor, paresthesia, paralysis, pulselessness, and pain. All of that below the site of the new joint, because we want to make sure that we're still getting adequate blood flow to those areas. We're going to monitor the wound drainage. As usual, purulent drainage, no good. Actions, pain management, wound care, mobilization. They're going to have SCDs, so compression devices or compression stockings afterwards to help with blood clots. They're going to be on anticoagulant therapy for as long as 4 to 6 weeks, potentially even longer, because we do not want any DVTs or PEs, right? There's actually machines that like do passive range of motion, and you can send people home with these. So that may be a thing. And then we need to educate them about proper positioning, turning, abduction, rotation, all of the stuff, right? When to bend over, when not to bend over, how to sit. You don't cross your legs anymore. That's a big one. And just making sure that you are following all those instructions and that you have some sort of caregiver support to help you with all of that, especially initially. After surgery, our person is going to be on opioids, so we want to talk about constipation, drowsiness, respiratory depression. They're going to be on anticoagulants, so we're going to do teaching related to that, right? Look for signs and symptoms of bleeding. Also look for signs and symptoms of a DVT, such as pain, warmth, and tenderness at the site. Pulses, maybe even check pulses, right? Diet, If on warfarin for anticoagulation, you have to limit or maintain consistent intake of foods high in vitamin K. So this is your green veggies, all right? These foods can interfere with the efficacy of warfarin. So we want to just be mindful that we are not overdoing it, right? Or we're eating the same amount that we used to. So they recommend 20 to 30 minutes of exercise 2 to 3 times daily during early recovery. The person may end up going to rehab, right, for help. We talk about using like a raised toilet seat, a walker, especially initially. Remove all fall risks around the house, rugs and cords, all of that. And then you're going to follow up with the surgeon to find out when you can resume normal function. All right, bone cancer. We have benign bone cancers, so non-cancerous, often asymptomatic, and then malignant, which are cancerous in nature, and can originate from either a primary or a secondary source. So osteosarcoma, not exactly known like the etiology. One theory is that osteosarcoma arises from rapid or abnormal bone growth and remodeling, triggered by an oncogenic agent during a time of cell proliferation or growth. And this may explain why it occurs commonly in children and adolescents. Clinical manifestations of osteosarcoma, common to other musculoskeletal health problems, right? So that honestly can delay diagnosis because we're kind of thinking the pain's related to other things, especially if you're an active person. So it could be pain, worse with motion, unrelieved by rest. All right, so that's a red flag. Pain may result in a limp, swelling, redness, decreased range of motion, weakening of the bone. Diagnostics, comprehensive history, and physical exam, right? We're going to want to find out how active they are. Have they had any injuries lately? What is that past medical history? We're going to want to know if they've had exposure to previous radiation therapy or chemo, all of that stuff. Treatment, ultimate goal for treatment is limb salvation, survival, and maintenance of quality of life. So treatments can go from radiation to chemo to surgical incision, bone biopsy. They may do biochemical analysis of the blood and urine just to see what kind of cancers you have, and that can result in a more focused treatment sometimes. They're doing a lot of cool things with cancer treatments these days. So there's options that weren't there before. So clinical manifestations, pain not relieved with rest, just like our infection. Okay. Most common sites are distal femur, proximal tibia, proximal humerus, middle and proximal femur, and occasionally the jaw with Paget's disease. Ugh, how crazy would that be? I've seen people with who have had jaw cancer before, related to like chew or tobacco smoking, and they get it removed. And I am telling you, that is the craziest looking thing. Like even as a nurse, it's crazy to look at. I cannot imagine what that would be like to have to live with that, right? And again, thank God for plastics because they can come in and do a lot of, restructuring of all of that. But initially, holy cow, is that ever crazy? Anyway, sorry, tangent. Common findings, localized pain. There may be a soft tissue mass that you can actually feel with palpation. So that would be one way to end up with like a bone cancer diagnosis, moving closer to a bone cancer diagnosis and ruling out other things. So the acute and chronic pain is related to the destruction of the bone. There's going to be physical immobility. There's going to be neurovascular dysfunction likely. We want to monitor for ineffective tissue perfusion related to the inflammation. And then if they do have possible loss of limb, like there is literally a grieving process associated with that. So huge psychosocial aspect, huge. Assessments, we are worried about ABCs, pain, neurovascular, um, function. Actions are going to be related to administering meds as ordered, working with the healthcare team, right? This is an all hands on board sort of situation. You know, nutrition. What do we have to think about OT, PT afterwards? If the jaw is involved, do we need to get speech involved? What about radiation and chemo? What's that going to look like? Who do they have at home to help with them? Teaching all about taking meds as ordered, avoid alcohol, all of that sort of thing. Teaching related to radiation and chemo, nutrition, high protein diet, understanding the disease process, right? Having a real understanding of what this looks like, okay? All right, moving on to musculoskeletal trauma, chapter 54. Sprains and strains. So sprain, ligament, strain, tendon. All right. And then we pretty much rate them. First degree, range of motion ineffective. Second, bruising, pain, tearing. Third, rupture, surgery. Diagnosis, x-ray, ultrasound, MRI, right? Treatment, rice, easy, okay? Especially for first and second degree. Third degree, likely going to need surgical intervention. So that would be something you'd have to educate and talk to your person about. If you don't remember what is involved with rice, definitely look that up. RN considerations, so assessments, neurovascular, pain, pallor, pressure, paralysis, paresthesia, pulselessness, history of injury, our action, meds as ordered, so analgesics, anti-inflammatories, rice, and teaching when to report worsening signs or symptoms, okay? Our person may need to go to PT, maybe OT. Sorry, I'm at the hospital with clinicals and I was just listening to the overhead go off. All right, it's not my students though. We're good to go. All right, so fractures. So, all right, bone is classified as a dense, irregular connective tissue made of osteoblasts and osteocytes, right? When we put excessive force on a bone, they fracture. So a fracture is a disruption or a break in the continuity of the bone. And there's numerous classifications for fractures. So you can have a complete fracture. This is where it breaks entirely across the bone, okay? The whole bone breaks, okay? Incomplete. This is where part of the bone is still in place, part of the bone is fractured, okay? Closed, that means that the fracture, this is closed or simple fracture, so the break is still within the skin. And then open or compound is when part of the bone is protruding through the skin. So open, obviously you have an open skin wound, and I always think compound because now you have two problems. You have the bone is broken and you have the fact that the bone is protruding through the skin, which now your biggest concern is infection, okay? You can have a displaced fracture, which is misalignments of bone fragments at the fracture site. So instead of being nice and lined up, which is non-displaced, you can have it like this, and that's displaced, okay? Diagnostics, x-ray or CT. Treatment totally depends on the type of fracture, where it is, and if surgical or non-surgical interventions are required. So non-surgical treatment of a fracture or a closed reduction, most frequent type of non-surgical fracture treatment, they manually manipulate and realign the bone, okay, under general anesthetic. And then so they realign everything, and then they put a cast or a splint, right? Splints are a form of non-rigid immobilization to maintain alignment of a bone. So like a soft cast, and then a cast is rigid. So fiberglass, plaster, and it's used on weight-bearing extremities, okay? Surgical repair requires an open reduction. You can have internal or external fixation. So fixation is when they use hardware, you know, pins, screws, rods, plates to fix whatever the heck it is you've done, okay? So these can be internal, or if you have a lot of muscle inflammation or soft tissue inflammation, sorry, not muscle inflammation, soft tissue inflammation, they may choose to do external fixation, because if you have a lot of inflammation going on, and they go in and try to do internal fixation, as that inflammation either worsens or gets better, like those rods and screws and stuff are not going to stay in place. So they may opt to do external fixation. All right. So we also may do traction. Traction is done before surgery. So traction uses like weights and pulleys and all this stuff to use force to realign, elongate those muscles, which helps reduce spasms, and basically it buys you time for inflammation to go down. So skeletal traction can use pins, tongs, screws, and wires that are actually surgically secured to the bone, and then weight is applied to provide realignment. Cervical traction is an example of skeletal traction, like a halo device. I don't know if you've ever seen somebody in a halo, but it's actually screwed into the skull, screwed in, okay? So as nurses, if we have somebody in a halo or some other sort of skeletal traction, one of the things that we get to do is pin site cleaning. So where those screws have gone in and they're holding the traction in place, you need to make sure that those sites stay clean and dry and free of infection. Then there's skin traction, okay, and this is like Bucks traction, which we'll talk about, but skin traction uses a flexible harness, boot, or belt to secure the extremity while 5 to 10 pounds of weight is applied to relieve muscle spasms and maintain the length of the bone. So Bucks traction is a form of skin traction. So, and Bucks traction is usually used for femurs or hips. So the thing with this kind of traction, if it uses a weight, all right, one thing as nurses is we have to make sure that that weight is still in place. Because if that weight is like sitting on the floor, that means it's no longer pulling against the fracture. So it's no longer doing what it's supposed to be doing. So if our person, if they have been adequately medicated, you know, they're probably going to have a PCA. They're probably also going to have scheduled meds with pain meds with us. If they are complaining of pain, one of the first things we need to do is double check that weight. Make sure it's off the ground. Complications related to fracture, neurovascular compromise, right? We are worried about blood flow. Because if blood flow is impeded, oxygenation is impeded, and that is not good. So one cause, you know, blood vessels can be severed, nerves can be severed. You know, that can be a problem. It can be by bone or even bone fragments, of course. So this is why we use like immediate traction, because it helps reduce that sort of complication. And then we worry about compartment syndrome. So compartment syndrome can be related to like a cast that we've put somebody in, or it can just be inflammation being contained by the skin. So with compartment syndrome, maybe there's a hemorrhage, maybe there's just edema and inflammation, and the body is just sending tons of fluid to the site of this injury. And of course, the skin can only stretch so far, right? And so what happens is the skin can end up splitting. What they'll do for compartment syndrome is called a fasciotomy, and they'll literally go in and do like a controlled surgical cut, slice into the arm just to relieve the pressure. Because we would rather do a controlled, sterile opening in the arm versus having that skin split, because then that skin is going to tear. It's going to be hard to put back together. We may not notice it at first, so we open ourselves up to infection. And of course, when we do anything, surgical, we clean the skin first. We make sure we're in a sterile environment. Whereas if that skin just opens on its own, you are at much greater risk of whatever skin pathogens you have getting into that open area. We also worry about compartment syndrome if we've put a cast on somebody. So if they continue to have swelling, and now we've put a cast on, which is a really rigid thing. Now we really, really worry about the neurovascular signs and symptoms of the extremity below that cast. So like if I have a cast on my arm, I'm going to be checking my fingers. Do I have capillary refill? Do I have pulses below the site of the cast? What's going on? So, and just like with compartment syndrome, even if I don't have a cast, you're going to be looking at those pulses below the site of injury. All right. Seeing what else you need to know here. Anytime you have a long bone break, like femur especially, we worry about fat emboli. There's fat and, there's marrow inside the bones, right? And that can get out and cause a fat emboli that just kind of travels through the vascular system. And then, of course, we worry about obstruction. Somehow we worry about pulmonary emboli, all the emboli. You can also have traumatic rhabdomyolysis. So this is a potential complication from injuries that result in compression and tissue ischemia, particularly crush injuries. So crush injuries produce continued compression of muscle tissue that restricts blood flow and precipitates tissue ischemia. Tissue ischemia catalyzes a vicious cycle of further inflammation, increased capillary permeability, and the release of more fluid and intracellular contents into the compartment and circulatory system. Myoglobin is an intracellular oxygen-binding protein found in skeletal muscle. It is one of the many intracellular components that spill out of dead muscle cells. So once in the circulatory system, myoglobin can travel to the kidneys, lodged in the nephrons, so the kidneys are unable to effectively filter proteins. You can end up with tubular necrosis and renal failure. Symptoms of rhabdo include severe flank pain, dark tea-colored urine. Anybody who has gone through a crush injury, we are going to be monitoring their serum myoglobin and renal function levels because we are just kind of waiting for this. You're going to do fluid resuscitation because it's hopefully going to help flush the myoglobin through the kidneys. Don't forget that rhabdo is also associated with multiple electrolyte disorders like hyperkalemia, hypophosphatemia, and hypo or hypercalcemia. Hypovolemia is a potential complication due to loss of blood that can occur with fractures, especially open fractures and big bones, right? Like femur area and all of that. We have big vessels running through those areas. So hypovolemia related to hemorrhage is always a concern. Slide 31, this talks about evidence-based practice related to compartment syndrome, and then there is a safety alert related to compartment syndrome. Compartment syndrome is considered a medical emergency, okay? So when we send somebody home with a cast, this is education we're going to want to do. Slide 32, also safety alerts. This is about long bone fractures and knowing that they are highly susceptible to fat emboli, what those signs and symptoms are. Also, other emboli. So take a look at this. Slide 32. RN considerations related to fractures, obviously vitals. We're going to keep PE, DVTs all in our head, you know, when we're looking at pulses, neurovascular assessment of the sites distal to the injury. Let's see, proper positioning, you know, traction, splinting, immobilization devices, you know, all of those things, make sure that everything's functioning correctly. We're going to do a lot of labs. We're going to look at myoglobin related to rhabdo, creatinine, creatinine phosphokinase, something, CPK. That is released with any muscle breakdown, and it is increased with rhabdo. So we're going to be looking at that also. And then, of course, our complete CBC. We're going to worry about our electrolytes, H&H's, all of that stuff. Appearance of the urine, because related to rhabdo, so I's and O's, because we're worried about kidney function here. So analgesics as ordered, antibiotics, anticoagulants, wound and pin care if needed, elevation, you know, gravity is always our friend with inflammation. So, and our site, if we can elevate it, we would like to. Ice, possibly heat, possibly, but more likely ice because of the inflammation risk. Range of motion, ambulation, repositioning, hydration and nutrition, all the things. And then when our person goes home, we're going to want to make sure that their caregiver is adequately educated about what needs to happen. Box or slide 34, sorry, box 54, healing of fractures. You don't have to memorize this. It's just kind of cool to read through the stages of healing, just to know what happens, especially if you end up working on an ortho floor, you know, just so you can talk intelligently about what's going on. This slide 35 is do's and don'ts of a cast. So this too is a huge like patient education area. So again, this is slide 35. All right, amputations, slide 36. So, you know, there's various reasons for amputations, right? But they can be pretty much traumatic or elective. So traumatic amputations can be blunt force trauma, like in motor vehicle accidents, motorcycles, accidents like if you're working somewhere and your leg is caught between two heavy objects, you know, if you're working at Costco and you get stuck between the forklift and boxes or something, right? Also pedestrian versus vehicle. Let's see, risk factors, other risk factors, sorry, reading my own notes here. If you engage in other risk-taking behaviors, you know, gunshot wounds, industrial jobs, using power tools, even lawnmowers and snow blowers. And then, of course, we have our vets who have been in like Iraq and Afghanistan. And there have been thousands of traumatic amputations among military professionals because of explosive devices and accidents that happen out in the field. So that also is a consideration. And again, all of this, I mean, think about the psychosocial aspect of a traumatic amputation, right? You go in with two legs and you wake up and now you have to figure out this whole new life, right? So a lot of psychosocial related to this. Elective amputations are usually due to vascular compromise, secondary to chronic illness. So for sure diabetes, right? Diabetes all day long. And then potential infections, peripheral vascular disease. So all of that. And you know what's really shocking when you get out into caring for people? These people, like especially if you've worked at a wound clinic or seen anybody with related to diabetes, just how essentially decrepit their feet can become because of the neurovascular compromise. Like they'll be losing toes and stuff. Their foot will look horrid. They'll have these crazy, crazy wounds and be completely resistant to the idea of an amputation. It is honestly, it's shocking. It still shocks me because you just think, how can you look at this and even want to keep it? I mean, the wounds can be horrendous. So I would say probably the grossest wounds I've seen are related to diabetes patients who are not taking care of themselves. Um, that's where I've seen like maggots and that sort of thing. And again, though, if you suggest amputations, it is crazy the pushback. So it's a weirdo thing. But as nurses, we have to deal with that psychosocial aspect of it. And we have to be the one to really help educate people and understand how this can help them lead to a better life. Because if they end up with an infection, it can become osteomyelitis real quick, and then it can spread real quick. And so a lot of times these people are looking at potential death or not a very good outcome, and definitely reduced ADLs and quality of life, right? So there we go. Slide 37, this is box 54.5. This is care for limb reattachment. So this is just kind of a cool little blurb. It talks about if they are able to reattach a limb, what is involved in that. And if you were to work on that type of floor where something like that is done, there's a lot of nursing care. So obviously, right? Slide 38 is a safety alert. Traumatic amputations cause serious disruptions in muscle, bone, and blood vessels. As a result, these patients have a significant risk of succumbing to hemorrhagic shock. The nurse should do the following: immediately assess the wound for active hemorrhaging, place a pressure bandage or tourniquet and monitor for effectiveness, obtain a CBC and type and cross for immediate blood transfusion according to the provider's orders, and prepare the patient for surgery to repair the severed extremity. So this is like working in the ED bay and they bring in a trauma, right? My guess is there's also standing orders for what labs you obtain, and likely a type and cross is going to be part of those standing orders. This is slide 39, complications related to amputations. The biggest one is probably hemorrhage related to traumatic amputations, just because there can be some large blood vessels within the extremity, and people bleed out really quick. So this is when you are massively transfusing people and just open flowing fluids into people, okay? We worry about hypovolemic shock, and that of course can lead to death. We also worry about infection. If you have a traumatic amputation, that amputation has not occurred in a clean environment. Never mind sterile, but not clean. So all of the skin things, if you see it a lot with motor vehicle accidents, especially motorcycles, they have drugged that limb across the concrete. Road rash, all the things that are now inside here. So infection, huge complication. We also worry about then contractures of the residual limb. Contractures are most often seen in patients with lower extremity amputations and are manifested by lack of movement and exercise in the residual limb. So these can be avoided by encouraging the patient to perform active range of motion exercises and participate in PT. The other weirdo thing is this phantom limb pain. And that is literally feeling pain sensation in a limb that's no longer there, right? It can be tingling, numbness, burning, all the neurovascular sort of things in this limb that's not there, okay? Typically, that sort of pain weakens over time, but it can be exacerbated by touching the residual limb. And we do actually call that a stump. Okay, that is actually the terminology. So by touching the stump, right? It can also be exacerbated by weather changes, stress, nervousness, exhaustion, further sickness. Most prevalent theory is that when the nerves are severed during the amputation process, sensory function of the lost limb relocates to the spinal cord and brain cortex, causing the continued sensation of pain from the amputated extremity. The administration of antidepressants and anticonvulsants, such as gabapentin, have demonstrated effectiveness in treating phantom limb pain. Mirror therapy has also been successful in treating phantom limb pain by reversing the relocation of sensory nerve function through visual feedback. I don't know if you know what mirror therapy is. I saw a show about it like 20 years ago, but they hold a mirror up. So you know how in a mirror you see the reverse image, right? So I hold a mirror up to my right limb, which is still present. Well, in the mirror, my eyeball sees it and my brain just translates it as to being the left limb because the mirror reverses the image, okay? So using this, the brain is then able to work through this sensory nerve dysfunction. And it really helps eliminate this phantom limb pain, which is so crazy because it tells you the brain is not as smart as it thinks it is, right? If I can just hold up a mirror and it can relocate that pain and rethink through it, crazy. So RN considerations related to amputations. Psychosocial is going to be at the top of the list, right? Psychosocial, and then neurovascular, those 6 Ps, making sure that we have blood flow, everything is oxygenating appropriately, and of course pain, okay? Pain, impaired skin integrity, ineffective coping. Like what if our person is just distraught, right? How do we deal with that? If they cannot see how this is going to work into their lives, it can be a lot. So as nurses, we need to know either we're comfortable having that conversation or we know who within our facility we can talk to or to come talk to our patient for us if we're not comfortable. And if you're not comfortable, that's okay. That's okay. But we need to know what kind of support we can find for our person. Assessment, obviously vitals, all the labs, CBC. We're always going to be watching those distal pulses, color, pain, all of that sort of stuff. If there's a wound or incision site, how is that looking? Don't forget that purulent drainage, always bad. We're going to want to keep a large bore IV in place, just in case. We're always kind of worried about hemorrhage and hypovolemia and that sort of thing. So we want a large bore IV. So if we have to infuse blood, if we have to infuse fluids, we can do it. We're also going to want to talk alternative pain management techniques because this pain doesn't just resolve in a week in a hospital, right? So there's stuff like a TENS unit, which actually uses little electrical pulses. And you can get TENS units for at home, or you can go and have therapy. There's CAM therapies, any alternative stuff that might help, right? And then of course, range of motion. And we don't want to put pillows underneath the remaining portion of the lower extremity. You don't want to put a pillow underneath that stump because you can end up with flexion contractures, right? And once contractures start, you can't undo them. So the best thing with contractures is to not let them happen in the first place. We're going to do ice for 15 to 20 minutes, no longer, right? Helps with vasoconstriction and decreases edema. We're going to worry about nutrition. This is going to take a lot of healing. So protein-rich diet, maybe splinting, Teaching is going to be related to meds, nutrition, hydration. There is a slide in here about compression dressing for limb wrapping. It's a figure 8 technique. You're going to want to take a look at that. All right. We start with that wrapping on 1 to 3 days post-op. You wrap distal to proximal. You start with minimal tension and then increase the tension. All right. They re-wrap that 2 to 3 times a day, and you keep it wrapped unless bathing. All right. If pain occurs, the wrapping is probably too tight. All right. But this limb wrapping really helps decrease edema, and it's going to help with fitting the prosthetic on the residual limb eventually. So this is a long-term game here, right? This isn't be in the hospital for a week and problem solved. This is a lifelong, now chronic essentially situation. So a lot of things to consider. Don't forget about wound care, signs of infection, range of motion, and community support, especially for our vets. You know, community support can be really, really helpful, because especially vets or anybody who's had something traumatic happen, there's a lot to deal with. So always keep that in mind. Slide 41, this is our figure 8 limb wrapping. So take a look at that. Slide 42, this is just about meniscus injuries. The menisci are semilunar shaped wedges of cartilage positioned between the tibia and femur of both knee joints. They cushion, protect, and stabilize the knee joint from shock during movement. So there's a lateral and medial portion to each meniscus and their menisci, and they're kind of shaped like a C. So they can be torn, basically, is the problem, with excessive twisting or rotational force. I know I was in a car accident where I was sitting with my knees up, like my feet up on the dashboard, and we T-boned somebody, and I now have a torn meniscus because of that. So anything that causes like undue pressure, tearing, rotation, stuff like that. So lateral meniscus is like more U-shaped, so it's a little bit bigger. It's not uncommon to get tears in that area. Usually, obviously, there's a lot of knee injuries. You can get ACL tears also. So pain experienced just kind of depends on the conditions related to the tear, like what happened. After that, you can have locking, clicking, or instability of the joint. You can have medial or lateral pain, tenderness, right? Diagnosis based on physical exam, also X-ray, CT, MRI, treatment, dependent on the size and severity, right? Smaller tears can heal on their own, actually with limited rest. Use ice, NSAIDs, that sort of thing. Maybe even total immobility for a little bit. But that's not often recommended because it's crazy how quick like muscle atrophy can occur, and stiffness. So really we try to stay away from being totally immobile for any length of time. They may do surgery, arthroscopic surgical repair is possible, right? Assessments, physical assessment, you know, is it impeding any range of motion, right, or sensation? We're going to do vitals, neurovascular checks. If there's surgical stuff, then wound site and dressing, obviously pain. We can do cold compresses, elevation, range of motion, anti-inflammatories. Teaching is basically going to be like reporting any worsening of signs or symptoms, okay? Because this, maybe you did more damage, who knows? Pain management, wound care, exercise, all the things, right? Carpal tunnel syndrome, slide 43. Carpal tunnel syndrome, most frequent compression neuropathy of the hands. Risk factors age, type of employment, and gender. So a lot of times this is related to typing on a keyboard, like how your hands are positioned. You end up irritating the carpal tunnel. I don't know. Um, but just irritating that area, and you end up with carpal tunnel syndrome. Women are 4 to 5 times more likely to get carpal tunnel syndrome, partly because of the smaller size of the carpal tunnel in women. So, and women, especially like our older, generations, the women were more likely to be typing. They were more likely to be secretaries back in the day. Now everybody uses a keyboard, so I'm sure the differences we see between men and women getting carpal tunnel is going to be reduced, because even though women still are at greater risk just due to the smaller size of the hands, men are using keyboards just as often as women, right? So that's probably going to change. But this is really related to repetitive motion of the wrist, and you end up with inflammation of the tendons and ligaments. And then the inflammation compresses the nerve, the median nerve. So it causes like sharp pain, numbness, and tingling of the hand. Grip strength can be decreased. Symptoms may initially occur intermittently at night, and then they progress if not treated. So one of the things they do to test for carpal tunnel syndrome is this Fallon's test. You relax your hands in a flexed position for 60 seconds, or by placing the back of the hands together, right, while flexing both wrists. If you have carpal tunnel, is going to compress the median nerve. So if you have carpal tunnel, you're going to get numbness and tingling, like when you do that, right? You're going to feel it. So, and then there's Tinel's sign, which is tapping the median nerve over the carpal tunnel at the wrist, and this will elicit like tingling over the nerve region of the wrist. Okay, so Tinel's sign is tapping the nerve, and you're going to get tingling, and Fallon's sign is like putting the back of the hands together, which compresses the median nerve, and you'll have the tingling and all of that. There are also like nerve conduction studies and stuff like that they will do. Treatment, non-operative, is like modifying the work environment, right? Also, if you've ever seen like the little wrist things that you can get to rest your wrist on when you're typing at your computer, that is related to helping reduce carpal tunnel, because it changes the positioning of the wrist and the hands while you're typing. They can do stuff like ultrasonic therapy, NSAIDs, steroid injections, maybe splinting at night, because they talk about the pain starting at night. And then, of course, there's surgical intervention. This is an outpatient, and all they do is basically go in and cut the ligament so that there's no longer pressure on the median nerve. They just go in and undo it. So RN considerations related to carpal tunnel, we're going to want to know their work or activity history, right? How many hours a day do they spend typing on a computer? Physical inspection, we're going to do, the physician is probably going to do Fallon's and Tinel's test. Do they have pain, tingling, paresthesia? Actions is talking about splinting at night, range of motion, anti-inflammatories, maybe an OT. Occupational therapy does that small muscle movements and whatnot. More specific ADLs. So maybe OT, right? Teaching is going to be talking about worsening symptoms, maybe even going to physical therapy, pain management, work activity modifications. Okay. So that concludes musculoskeletal. Not too bad. And this concludes Module 9, your very last module. So thank you guys.